Hey there, welcome back to another episode of Community Health Paramedicine. Today we're going to be focusing on chronic disease management. Now, this is also a large part of what we do in our day-to-day, so most of this is going to be review. You do get continuing education credits for the time that you are spending here listening to lectures, so you can tuck those away for your national registry or your state recertification when the time comes. So think of it as a win-win. It's always good to go back and look at our chronic disease management. We have your typical CHFers, COPD, diabetics here in Western North Carolina are some of our biggies. So we're going to touch on some of those things and kind of what it means from a community healthcare perspective. It's a little bit different when it comes to processing. All right, so what I did is I broke this PowerPoint up into 3 sessions because it was 177 slides and I would get tired of hearing myself talk, and you guys would definitely get tired of hearing about it. So we're going to talk a little bit about cardiac, respiratory, and then GI conditions. We're going to about slide 59 before we pause for this episode. So chronic disease is any medical or psychological condition that continues for months or even years. These conditions may not be curable, but they can be managed over time. Examples include arthritis, diabetes, and even depression falls within that category. A community paramedic, our role is different. It's different than our 911 response. Here, we are helping patients live better with these long-term conditions that they have. So we must be prepared to do more than just treat emergencies. We need to access and assess and monitor our patients' progress or notice when they are declining. Those small little things may lead up to big consequences. So we need to make sure we are monitoring their progress or notice when they are starting to decline. We're supposed to connect them with outreach services, provide support not only to the patient but also to family and caregivers. Our work, it extends beyond medicine. It's about building trust, rapport, as well as support systems. Self-management is key for them to be successful. This means the patient and their family understand the disease and can act on the symptoms. Our goal is to empower patients to care for themselves as much as possible. This requires willingness and the right resources. They also have to have physical ability, financial stability, as well as emotional support. Our role is to guide and encourage them along in this process. Patients are more likely to manage their condition well when they feel independent. 2 big incentives for patients are autonomy and self-determination. In other words, they want to feel like they're in control of their health, not that their illness is in control of them. As paramedics, we can reinforce that independence. We measure success in self-management by looking at outcomes. Is the patient's health improving? Are complications being prevented? Are they staying out of crisis situations? These are the markers that tell us self-management is working. How does a patient achieve self-management? Well, it often comes down to the basics. Self-monitoring their symptoms, organizing medications correctly, having strong communication with their providers, and understanding their disease. These skills are what help patients stay stable at home. As community paramedics, we can play a huge role in building these skills. We provide education about the disease, we act as navigators, connecting patients to resources, and we encourage better communication with doctors, pharmacists, and caregivers. So think of us as coaches that are on their healthcare team. Another part of our role is ongoing monitoring. We track the patient's progress at each visit, and we help them recognize when their condition is no longer under control. That's the point where the plan of care may need to change for them. We are the eyes and the ears that help keep small issues from becoming big problems. For self-monitoring to really work, patients need education and support. I cannot stress that enough with this program. We have to give them the right tools, whether that's printed material on their diagnosis and going through it and highlighting things with them, phone apps that maybe need to be installed and helping them, showing them how to install them, or stoplight action plans. They need to understand how to regulate their own condition and believe that they have the power to do it. That sense of self-efficacy is what keeps them going. A key piece of self-management is medication inventory. Patients often take multiple prescriptions or polypharmacy, and sometimes herbal or over-the-counter remedies as well, and we've touched on this briefly. We need to help them review what they are taking, confirm they're using the right medications, and make sure there are not any duplications or interactions. Something as simple as a medication list can save lives, and make sure it's complete. Many of our patients are on more than one medication, as we mentioned, and those over-the-counters. So we need to talk to them about, why are we taking this prescription? What is it helping within their body? Remember, it's not just what's prescribed. That may mean asking careful questions and encouraging honesty about what they're really taking. A lot of people around here like to use herbal supplements, which is fantastic, but there could be some serious consequences if you mix those herbal supplements with different types of medication. Even something as simple as drinking grapefruit juice daily can have a serious effect with multiple medications. Motivation is critical. Patients need education, but they also need encouragement. Motivational coaching, emotional support, outside resources, and nutritional education can all make the difference. Sometimes just having someone believe in them helps them stay on track. We all want someone to just have faith. When it comes to managing chronic diseases, our responsibility is threefold. Monitor the patient's conditions, educate them about their illness, and manage their ongoing needs. Each of these steps builds towards stability and fewer emergencies. Remember that monitoring and management practices vary by program and also by medical direction as well. Always stay within your scope and follow local protocols. The goal is to adapt the care plan to the patient's needs while keeping safety and consistency in mind. We're going to start with some common cardiovascular conditions. So here in Western North Carolina, these are running rampant. So coronary artery disease, CAD, this happens when plaque builds up in our coronary arteries, narrowing them and restricting the blood flow. It is a progressive disease linked to inflammation and metabolism. Patients with CAD often don't realize how much it's impacting their body until symptoms become serious. This has been found in children as young as 9 years old, if you did not know that. So when monitoring a patient with CAD, ask about symptoms like chest pain, jaw pain, shortness of breath, especially with exertion. Nausea would be another one. These symptoms can be small at first, but can quickly progress into emergencies if we leave them unchecked. During our physical assessment, we are listening for murmurs. Get good at listening for heart murmurs or abnormal heart sounds. I'm going to put some visuals into your course. Please go in and make sure that you go through and check those visuals out on how to properly do this. We're also looking for swelling within their legs, any edema, pitting edema, jugular vein distension, rales in the lungs at the bases. These findings give us clues about how much the heart is struggling to circulate the blood effectively. Management is about prevention and stabilization. We're going to encourage smoking cessation programs, healthier eating habits, and lifestyle changes like exercise. Make sure patients understand their medication and follow up with their providers. Some may eventually need interventions like stents or bypass surgery, and discussing those options down the line may give them a better understanding at managing their self as a whole. Education should focus on causes. Poor diet, sedentary lifestyle, and high cholesterol are huge contributors to this. Patients often don't realize the role that daily choices play, even the small choices. Our job is to help them connect these dots and encourage healthier patterns before transport becomes necessary. Congestive heart failure, one of the #1 reasons that we have hospitalizations here in Western North Carolina for our active agers, as I like to call them. Congestive heart failure is when the heart's ventricles can't pump enough blood to meet the body's demand. It can be due to systolic, diastolic, or right-sided dysfunction. Patients often describe they're fatigued, may have shortness of breath, they may have swelling in their extremities, may have ascites as well. They may not understand what's happening in their body. So our role is to break it down simply. The heart is working harder than it should and fluid is backing up. One of my favorite things to do when I'm instructing is to draw a picture and label it and break it down in simple layman's terms. Another good trick with AI is tell AI to explain it to you like you are a 5th grader, and then use that whenever you are going through this with your patients in the field. Risk factors for CHF include diabetes, hypertension, obesity, metabolic syndrome, and previous heart attacks. Even viral infections can contribute to this. When you visit these patients, always consider their risk profile and how multiple conditions can compound to also strain the heart and put more exertion on it. Monitoring CHF patients is very critical. Confirm who their primary provider is and ensure you understand their plan of care. A key part of assessment is checking for pitting edema. That is swelling within your legs or feet that is caused by fluid retention with a right-sided heart failure. We grade edema on a scale. So +1 would be a slight indentation when you press into their skin and it quickly disappears. +2 is a deeper indentation and it disappears in about 10 to 15 seconds. +3 pitting edema is when we have noticeably deep pits that last more than a minute and their legs look very swollen. And then +4 is very deep pitting. We have indentation that remains 2 to 5 minutes and their legs are swollen grossly. So documenting this tells us how severe the fluid buildup is and whether the conditioning is worsening. Education is where we can really change lives. Many CHF patients do well with a stoplight action plan. So green for stable, yellow for warning symptoms like swelling or fatigue if they have that. Red is for emergencies like shortness of breath or chest pain. There are some resources from the American Heart Association to reinforce the messages as well that we are trying to drive home to them. So come prepared with pamphlets, arts and crafts, whatever you need to do to help get that message across. Those teeny tiny small daily choices like weighing themselves every day can prevent hospitalizations. Hypertension, a lot of hypertensive patients in our area. So this means consistently elevated blood pressure greater than 140 diastolic or systolic or greater than 90 diastolic. It can be caused by cardiovascular issues, kidney problems, liver, or neurological conditions. It's often called the silent killer, especially for people that are not paying attention and monitoring their blood pressures. They may not even realize something's going on. They just have minor symptoms until some massive complication arises. So our goal is to help patients understand the importance of consistent monitoring and lifestyle changes. When you monitor blood pressure, make sure that we're taking a full set of vitals, manual, please, full set of vitals and comparing both arms. A difference between arms can sometimes indicate vascular issues like arterial narrowing. So encourage patients to measure their blood pressure at home regularly at the same time when they get up in the morning and log those results. This helps both us and the providers catch problems early on. Management is about sticking to the plan of care. That includes medication compliance, but also diet changes, exercise, and reducing alcohol. Many patients stop their medications when they feel fine. We've had that patient, oh, I don't have any conditions. I take a medication for that, so I don't have COPD. It's cured me. But that's when the problem creeps in, is when they just stop because they feel fine. Our job is to remind them that hypertension doesn't usually have symptoms, but it can still cause massive problems, life-threatening things like strokes, heart attacks, and even kidney failure if it's left untreated. Education should focus on diet as well as exercise. Teach parents about reducing, or your patients about reducing salt intake, how they can stay active by doing little things such as incorporating walks to the mailbox or with their dog, or walking to their neighbor's house daily and back. Even set up a plan with them and start elevating those goals a little at a time till they get to that long end goal of maybe a walking goal of going for 1 mile way down the line. Also talk about moderating alcohol. So talk about what a healthy amount of alcohol is for them to have weekly, and try to start slowly pulling it back with them. Show them how to take their accurate blood pressures at home, how they need to be sitting, what they need to be doing, not crossing their legs, all those good things. The ultimate goal is reaching target numbers with medication and lifestyle, so we're going to keep them out of crisis zones. So on to our respiratory conditions. We do have multiple patients with respiratory issues. Asthma being one of the main ones, is a chronic inflammatory condition that narrows the airway and limits airflow. Patients may experience coughing, wheezing, shortness of breath. It can flare suddenly, can be triggered by allergens, irritants, even stress can cause it to suddenly flare up. The key is helping patients recognize and control their triggers and then putting a plan into place before they spiral into an emergency. When you assess your asthma patient, look for the expiratory wheezing, shortness of breath. Ask about frequency of nighttime symptoms or activity limitations. How often are they hitting their puffer? So how often are they using their emergency inhaler? These details might help determine how severe their asthma is and how well it's being controlled. So remember, poorly controlled asthma increases that transport of them needing one of our 911 trucks. Monitoring asthma involves a full respiratory exam and often a review of their environment. It could be triggered by their environment. Are they exposed to smoke? Do their partners smoke? Do their roommates smoke? Is there a lot of dust within their apartment or their house? Do we have our loved pets that are triggering it, or anything else that they can think of? Even some sorts of laundry detergents sometimes can trigger these attacks. Effective monitoring and patient education can decrease the need for aggressive treatments or emergency interventions. So prevention, prevention, prevention. Managing asthma means focusing on both environment and medication. Encourage patients to control factors that make their symptoms worse, like those allergens and irritants and even strong odors. Walk through the house with them and talk about maybe some areas that they are when they are triggered. Maybe it's an older home with carpets in it, or maybe they have throw rugs that have not been washed. Those little tiny things can actually make a huge difference. So teach them how to monitor lung function and peak flow meters if that's available. Medication adherence is also key. Those controllers, their inhalers, prevent flare-ups, and rescue inhalers treat those acute symptoms. So stress the importance of using them when they need them and using them correctly. Education is all about empowering the patient. Help them set goals based on their care plan and also teach them how to track their symptoms. They might not even realize that it's a symptom. You may have to point that out to them. A stoplight action plan works here too. Green means they're breathing well. Yellow signals that's warning signs, and red means seek immediate help. Sit down and speak with them about a stoplight care plan and what that looks like and how to change from yellow to green, and when we get to red, what that process needs to look like. This keeps the patient actively involved in their own care. COPD. So chronic obstructive pulmonary disease, asthma also falls within this bucket, but COPD is another long-term condition caused by chronic inflammation and airway obstruction. It progresses slowly, so patients may not realize how serious it is until they are struggling to breathe. In the U.S., it is the third leading cause of death, with over 15 million people diagnosed currently. One challenge with COPD is that patients often ignore or adapt to their worsening breathing. They may avoid activities rather than noticing how limited they've become. This makes it essential for us to assess carefully and ask questions like, have you noticed you're doing less than you're used to? These subtle changes can be red flags. When we monitor COPD, do a complete and full respiratory exam. This means listening careful to lung sounds. Assess their work of breathing. If you have a hard time listening to lung sounds, there are a lot of new fancy schmancy stethoscopes out there. I am a firm believer on making technology work for you. So invest if you need to in a nice stethoscope. It's amazing the difference that it makes. So note also if they're using accessory muscles whenever they are breathing. Evaluate what triggered any changes that they may have. Did they have a recent infection? Maybe they stopped taking a medication or they changed their medication. Did they have an exposure to an irritant? Did they change their laundry detergent? Do they have a new shampoo that they're using on their dog? So help them pinpoint the cause, and that can help guide the intervention. Management focuses on catching exacerbations early and preventing the progression. Encourage patients to stick with their plan of care, recognize the flare-ups, and act before things worsen. Smoking cessation is the #1 intervention. Without it, no amount of medication can fully control COPD. Be supportive, but be realistic. Quitting is very hard, but every attempt matters, and give them that positive encouragement to keep them going. Our education has to be tailored to our patient's health literacy level. Once again, I mentioned AI, putting it in and having explain it to you like a 5th grader, and then using that for talking points is so much fun. It's so key. So talk with them about their own symptoms and experiences. Teach them how to manage yellow zone symptoms like mild shortness of breath or increased spit and mucus before they become emergencies. When patients feel prepared, they're less likely to call for transport. They feel like they can control their own health. Moving on to our GI conditions, or gastrointestinal. So constipation being one of the biggies, it's defined as producing fewer than 3 stools in a week. It can be influenced by multiple things, stress being one of them, travel, pregnancy, or aging. Many medications, as we know, opioids, iron supplements, and acids can also play a role with causing constipation. Patients may feel embarrassed to bring this up, so you're going to have to ask them, just like you would in the truck, how are your bowel movements? What did they look like? Has anything been abnormal recently? So monitoring constipation starts with good questions, like how often do you have a bowel movement? And can you describe it for me? Patients may not think about these details until you ask them. They're not like my daughter, who likes to show me every time she has a bowel movement. They keep it hidden. Knowing their normal pattern helps us determine if this is a new issue or an ongoing struggle for them. When the patient answers, it may be helpful to describe the various stool types by using a tool such as our Bristol stool scale. This is our poop scale. Poop is fun. This kind of helps them visualize what their poop looks like. So when discussing bowel movements, talk about the frequency, consistency, and whether the patient has to strain or not. The Bristol stool scale is a helpful visual tool that categorizes stool from hard pellets to watery diarrhea. It helps patients describe what they're experiencing, and it helps us guide their care more effectively. Managing constipation starts with finding the cause. Is the patient dehydrated? Are they on medications like those opioids, acids, or antacids, or even calcium channel blockers can cause constipation? Addressing the root cause makes a big difference. Lifestyle changes might be like adding fiber, fruits, vegetables to the diet, increasing water intake, measuring the water intake daily, getting them to get a new water bottle, making them excited about it. It's simple, but it can be very effective. Education should be geared to prevention. Encourage them to talk openly about bowel changes instead of ignoring them. Help them understand that prevention, like staying hydrated and eating fiber and staying active, is much easier than treatment after the fact. On the other end of the spectrum, diarrhea is a significant change in bowel habits with increased frequency, looser consistency, and greater volume of stool. It can be acute, usually viral or bacteria, or it can also be chronic. Either way, diarrhea can be very serious for our patients who are vulnerable to dehydration. So when monitoring patients with diarrhea, remember that most cases are short-lived and self-limiting, but elderly patients, or young children, or those with our chronic conditions can dehydrate quickly, even early on. So look for signs of dry mouth, dizziness, decreased urine output. They may indicate that intervention is needed. Our red flags with acute or chronic diarrhea should or include sudden changes such as watery discharge, bleeding, or extremely foul change in smell composition, so incredibly foul smelling stool. Management is generally supportive. The focus is on hydration and electrolyte replacement. There is a huge misunderstanding between hydration and electrolyte replacement. I find a lot of people don't understand that electrolyte balance is so important. So they may overhydrate with water and actually completely flush all of their electrolytes out. So please do some good detailed education around electrolyte replacement. Encourage patients to sip fluids frequently or use oral rehydration solutions. In most cases, no medication is needed, and removing the underlying cause and staying hydrated is enough. Education should be practical. Teach patients to keep a stool log, paying attention to frequency, consistency, and any triggers. Help them understand what's normal and what's not normal. Encourage them to seek help if diarrhea persists, worsens, or comes with an alarming sign like that blood in the stool or severe abdominal pain. So now into our genital urinary conditions. Dysuria is pain or discomfort with the urination itself. The common cause is usually a UTI. Number one cause is generally a UTI. Now remember, with our geriatric population, sometimes they're not even going to feel any discomfort or know they have a UTI. This can also result from structural changes, though, in the urinary tract. Patients often describe burning or difficulty starting their stream of urine. A UTI can cause significant inflammation and discomfort. In severe cases, even complete urinary blockage. Patients may be embarrassed once again to talk to you about their symptoms, so we need to ask directly and approach the topic with sensitivity. When monitoring dysuria, assess whether the issue is due to kidney disease, a change in urine production, or lower UTI infection. So we're going to do a detailed assessment and encourage patients to describe the change in color, any odor that they've noticed, how much volume they're able to get out. Those are important. Those are definitely important, and how often they are going and if they have any pain or discomfort. Management, once again, usually focuses on hydration and encouraging frequent urination to help flush bacteria out. Most UTIs resolve within a week with proper treatment. Remind patients to complete prescribed antibiotics if given, even if they start to feel better, and to avoid holding urine for long periods of time. Education for dysuria should focus on prevention, stress the importance of hydration, proper hygiene, and completing treatments. Also be mindful that some patients may feel uncomfortable talking about these urinary issues, especially with a provider of the opposite gender. Building trust and showing respect is going to be key with this one. Kidney disease. So this occurs when our kidneys can no longer filter waste or fluid properly. This can be an acute, sudden onset, could be caused by infections, dehydration, or even ischemia, or it can be chronic and progressive. Patients often don't notice symptoms until the disease has advanced, which is why monitoring is so crucial. Renal disease is classified into 5 stages, usually based on the glomerular filtration rate, or easier to say, or GFR. I prefer the easier things. Blood, urea, nitrogen, and serum creatine, our labs, are also so important to know these lab values, and they can indicate kidney function. These numbers guide us in determining the severity of their disease. When monitoring these patients, always establish their normal lab values if at all possible, urine output, and their GFR levels. For end-stage renal disease, dialysis, or even transplants may be required. This can be terrifying for them, so having someone they can talk through that process with is going to help them with understanding the direction of their care. Watch for sudden changes in urine output, swelling, or blood pressure, all of which can signal worsening kidney function. Dialysis is a common treatment. There are 2 main types, our hemodialysis and our peritoneal dialysis. It's important to know which one your patient uses and be alert for complications like infection, bleeding from our port or access site. Patients who miss dialysis sessions can decline quickly. We know they're one of our #1 transports. Management focuses on diligent monitoring of urine production and comorbid diseases such as diabetes or hypertension. Close attention to our GFR trends and our lab values also help keep our patients safe and at home. Encourage them to stay consistent with their treatment plan, especially if dialysis is part of their routine. Help set up a barrier to care ahead of time. If they don't have transport, if something falls through, if the ambulance is supposed to take them is late, what are their options? Identify common barriers and then set up some goals around those barriers. We are to our last slide for this lecture. So with closing, education should focus on helping patients understand their disease and its symptoms. Encourage them to ask questions about special diets, medications, and supplements they're taking, but remind them to check everything with their medical director as well, or their doctor. So teaching them to track swelling, weight changes, or changes in urination helps them recognize when to seek help early. In our area, we see a high number of patients with cardiac issues, respiratory and GI conditions. Heart disease, high blood pressure remain some of the leading causes of emergency calls, especially in our rural populations. COPD and asthma are also common, with flare-ups often linked to smoking or environmental triggers. On the GI side, issues like constipation and diarrhea may sound minor, but they frequently lead to dehydration and complications that bring patients into our ER. The reality is, we'll see these patients often, sometimes weekly. Because these conditions are so widespread, our role as community paramedics is to catch the problems early, support self-management, and guide patients towards healthier choices so we can keep them stable at home and avoid those unnecessary transports. That's all I have for you today. Hope that was helpful and informative. If you have questions, please hit me up, and I'll see you for the next episode.